So
you can see my screen. Okay, great. So let's begin. Yes?
So good morning, everyone. Good afternoon. So welcome to this session. We'll try to go quick. So in this session, I've got Professor Swellen Miller, who's going to do a presentation for us on the e-motive implementation of a project, PPH bundle, to enhance guideline adherence and improve maternal outcome. So Professor Swellen is a professor at the University of California, San Francisco, School of Medicine. She's a nurse midwife by background and has over 40 years experience as a clinician and global researcher. She's well published, and she's one of the co-authors of the Lancet Maternal Health series, the Too Late, Too Little, Too Late, Too Much, Too Soon, and has been working with WHO and others on the development of the PPH bundles. So please, Swellen, you can start and tell us why emotive is not about emotions.
Okay. Thank you. It's actually somewhat emotional. Good evening, good afternoon, and good morning to all of you who are here in the room. The sun is just coming up here in California, so it's really important and a pleasure for me to be speaking to you about emotive, an implementation project for postpartum hemorrhage clinical care bundle to enhance guideline adherence and improve maternal health outcomes. The logos below you'll be seeing throughout the presentation represent this rather large and impressive collaboration of many universities, research centers, and clinical care settings. A little bit of background, because a lot of this has been discussed and some terms have been used in the last day about bundles, and I wanted to just sort of go through our timeline. In the 2016 Lancet Maternal Health series, we tried to answer questions about why so many women are still dying from pregnancy and birth despite technologies, new interventions, increased facility births, and published guidelines. The group that I worked with, the 20 international experts on the article Too Little, Too Late, Too Much, Too Soon, our findings were looking at the guidelines and looking at studies of adherence, that looking into facilities, there was a lack of dignity and respect in childbirth, there was a lack of early recognition and early action for complications, what we call the third delay, and there was a lack of adherence to evidence-based care. In 2018, WHO and the Bill and Melinda Gates Foundation asked the question, would a postpartum hemorrhage bundle comprised of evidence-based technologies and strategies improve guideline adherence and improve outcomes? If so, what interventions would be included in a postpartum hemorrhage bundle? The group of Bill and Melinda Gates Foundation, WHO, my university, UCSF, Mass General Hospital, and the Institute for Clinical Effectiveness and Health Policy from Argentina developed a Delphi consultation on postpartum hemorrhage interventions. We were doing this to look at factors contributing to the success of bundles, and that is, what is a clinical care bundle? Yesterday, I think the term was used a lot, but I want to be clear and sort of break my timeline here by discussing how what our definition was, the definition that we used for making this bundle. The Institute for Healthcare Improvement, IHI, which has worked largely in bundles, defines a bundle as a small set of evidence-based interventions for a defined patient population and care setting that, when implemented together, results in significantly better outcomes than when implemented individually. What IHI and many others have discovered and have published data on is that bundling care can improve the quality of care and the efficiency of care delivery. What's not included in this definition, but what we discovered in our literature review, was that it's not just the clinical activities, the physical package of the bundle, but success is often determined by teamwork, communication, cooperation, and leadership. So for us, this is an important part of the bundle as well as the interventions. So getting back to our timeline, in 2018, the WHO consultation was held, and the article about this process has been published in IJGO. Again, we only use potential interventions from the World Health Organization 2012 and 2017 evidence-based interventions. The primary response PPH bundle, IV fluids, uterine massage, uterotonic medication, and TXA if less than 3 hours post-delivery. The bundle includes 2 doses of uterotonic and 2 doses of TXA. If that doesn't arrest bleeding, we need to move on or escalate to a refractory bundle. But our work that we'll be describing here is simply about the primary response. In 2019, the Bill and Melinda Gates Foundation called out for a postpartum hemorrhage bundle implementation project. Our response, our being this group of individuals and organizations below, is the collaboration that became our emotive project. And the purpose was to address challenges to implementation and adherence to evidence-based postpartum hemorrhage guidelines using a bundled approach. So we wanted to address these challenges, and our potential solutions I'll describe in the next few slides. Challenge number 1, as previously mentioned many times, are the delays in detecting postpartum hemorrhage. And because of these delays in detection, life-saving treatment is not promptly initiated. Our solution is early detection and treatment of PPH, the E in emotive, which we're using. Some people will be familiar with the plastic closed and calibrated or not calibrated blood collection drape. The challenges of implementing the postpartum hemorrhage guideline and solutions. Number 2, delayed or inconsistent use of interventions, especially we found for TXA, but also for all of the other elements of primary response. Our solution is the emotive bundle, and I've already listed what the elements are: early detection, massage, etc. I'm not going to go over them all here. If this does not result in cessation of bleeding, then we need to escalate care for the treatment for refractory PPH. I will mention the E here, the examination of the genital tract, because it wasn't included in the previous slides, but has been noted to be a very important concept. So another challenge that we're trying to address in this project is that many health providers do not follow the postpartum hemorrhage guidelines. And our solution for this is an implementation strategy that targets the capabilities, opportunities, and motivations for behavior change, a theory and framework of behavior change called COM-B. And this comes to us, the leader is Dr. Fabiana Lorencato, and she is at the UCL Center for Behavior Change. This larger slide just shows that the capability, motivation, opportunity can lead to behavior change. And there has been, and we certainly know from our study of the literature, demonstrated barriers to bundle implementation, but we want to address those barriers as well as discovering any new barriers that hasn't been found in the literature but might be particular to postpartum hemorrhage or particular to the countries that we're working in. So here's a basic outline of our emotive program. The sites are Kenya, Tanzania, Nigeria, South Africa, and Sri Lanka. As you can see on our timeline, COVID hit very early in our process, so it has and probably will affect the process. These 4 squares, the green squares, are sort of our pre-trial work, which includes formative work. Yesterday, I know many people brought up the low quality or potential low quality of medicine and supplies. So one of our partners, the Concept Foundation, we're working to assure the quality of medications. My little circle here is on the formative work. So I'm going to go into somewhat detail in the next couple of slides. For the formative research, we're doing mixed methods approach to answer these research questions. How is postpartum hemorrhage currently detected and managed? What are the individual sociocultural and environmental influences on postpartum hemorrhage detection and management? And what are the potential barriers and enablers to implementing the emotive care bundle? And we do this to inform the development of the implementation strategies to overcome the barriers. And as a note, implementation strategies are specific methods or techniques used to enhance the adoption, implementation, and sustainability of a clinical practice or program, in this case, bundle. So those are our research questions. Our methods, this is led by Dr. Megan Boren and Shahinur Akhtar at the University of Melbourne. We're conducting 10 to 15 IDIs per country with a range of healthcare providers on their current practice, barriers, and opportunities for implementation. We're conducting 800 online surveys, and we're doing systematic review of Cochrane guidelines, as well as a qualitative evidence synthesis of both prevention and treatment. This much more complex picture, we took it from the basic outline, and now we've expanded it to include all of the work that is being done. Probably doesn't include all the work. It's such a complex intervention. But the little square, the red square you can see, after the formative research, we will develop a logic model, and then we will take our findings to the co-design workshops. The co-design workshops is to really develop the implementation strategy. We'll triangulate our findings, we'll report back to the country teams, and we will conduct these workshops to refine and adapt the implementation strategy to the local context. That's not all. Before we do the clinical cluster trial, we will trial the strategy in non-study facilities, obtain feedback and outcomes, go back and do course correction and adaptation, and repeat that cycle before we finalize our strategies. So those are our adaptive cycles. Right before we do the implementation, we'll train on the bundle, and this training will be the bleeding after birth package, which will be adapted for the emotive bundle. And again, we thank Japigo for their cooperation in this part of the project. We get now to the intervention, the random parallel cluster trial. And this is a multi-country parallel cluster randomized trial. There's a baseline control phase, a mixed methods formative research, and process and health economic evaluations. The PICO for this randomized cluster trial at the population, for the population, it's at the cluster level, our health facilities, and you can see some of the criteria for entry into this cluster, and I'll go over that a little further. Our research participants are all healthcare providers attending vaginal births in the clusters. The interventions, again, strategy for early detection to trigger a first response, the motive bundle, and the implementation strategy. Our comparison is the usual care with the dissemination of the current guidelines. The outcomes, primary is a composite, severe PPH, postpartum laparotomy for bleeding, or postpartum maternal death from bleeding. We have a multitude of secondary clinical outcomes mainly, and we can, anyone wants to ask me more questions about what they are, but very important as secondary outcomes are implementation adherence, resource use. they are very, very crucial to the success of this project. Our sample size, 80 clusters, the average of 2,300 vaginal births per cluster per year. Our aim is to be able to collect data on 337,920 births with a 2% PPH incidence that should have us a very large sample size, 6,800 postpartum hemorrhage cases, which gives us over 90% power to detect 25% relative reduction in that primary outcome, and we want to reduce it from 2% to 1.5%. I'll rapidly cover our progress. Country visits have been conducted both in person and virtually. The secondary level facilities are our 80 health facilities, and that is, they deliver 1 to 4,000 births per year with the incidence rate of postpartum hemorrhage of 2%. And this slide shows the distribution of these clusters. Our main trial protocol, formative protocol, concept foundation protocol have been submitted with full ethical approval granted by now by the University of Birmingham, our sponsor, the University of Melbourne, Nigeria, and we just heard this morning, Kenya. So we've also hired staff in country, and we're moving forward now to the formative mixed methods research. And we are going to begin data collection in Nigeria and following shortly Kenya, perhaps South Africa, and by October, Sri Lanka. As I said earlier, COVID-19 has and may further impact these dates. So in conclusion, this is an innovative mixed methods implementation project, formative mixed methods with a behavior change framework, the COM-B. The intervention is the randomized cluster trial of motive bundle and the implementation strategy with a very ambitious sample size based on the anticipated number of births per cluster per year. If it's successful, we hope to see it result in a package of a postpartum hemorrhage bundle and intervention strategy disseminated via WHO guidelines. And we want to thank you for participating with us and all of these organizations. This is a contact information for the clinical trials team, Leanne Beeson at the University of Birmingham. And I will not name everyone, but I want to be sure to give a written out shout out to our lead investigators and our distinguished country PIs. And with that, I hope we're going to open up to questions. Thank you.
Thank you very much, Sarah, again for that presentation. Like I said earlier, I think this is a great work. It's work that for me touches something that an aspect of care that is close to my heart, because we keep on struggling with managing postpartum hemorrhage. It seems like no matter what we do, we still keep losing women from postpartum hemorrhage. Yeah, so people, we have about just 5 minutes or so or less for questions. There was a question earlier from Kathleen around this work. So essentially what her question was concerned about is what we may be able to learn about implementation of the bundle. I think this is in the primary health care. So a key framing from advantage of the bundle. I think there was a presentation by Jeka yesterday around this. So I'm not sure if you have understood the question.
Are we talking about the primary healthcare level?
Yes.
Is that where this is focused?
Yes. So what can we learn about implementing these at that level?
Well, this is not set at the primary healthcare level, but I believe there will be a lot of lessons learned of what is possible. Certainly the first response bundle can be performed anywhere. And I think that the lessons that we learn, we can adapt to the primary care facilities using these same technologies and working towards adapting the implementation strategy for a different setting.
Okay, thank you very much. So there is another question. We can take it quickly. Okay. Just wants to get a clarification for the early detection of PPH. So the plastic drapes with that will be provided as shown with the yellow and red markers. Providers encouraged to do what are providers encouraged to do with each of these markers?
Okay, that particular photograph showed an alert line at 350 and an action line at 500. I'm not sure yet if we're going to use those markers or just use the calibrations. So I can only say that usually in research when we've been using these, we've been talking about a marker at 350. This is an alert. This woman has already bled a little bit more than normal or usual, and now once it gets to 500, that's to trigger the action.
Okay, thank you very much. So for me, one last question, which is sort of ties in with the question that we've just asked around the calibrated drape. So, and also in the aspect of detecting. So sort of two questions. One issue is most of the story that I get in Zambia is a woman that's apparently delivered okay, no issues. Then hours later is found in a pool of blood or is found in shock. I call them silent bleeders. So these drapes are suggested for all patients that come into a labor ward. And of course, most of the women, when they deliver, they have a maternity pad placed. How does that, is that going to be done away with? So after delivery, there's no bleeding, somebody's given a maternity pad to put on. So how does that affect the measuring with it?
Yes, well, the primary response should be triggered by an excessive blood loss, clinically judged by the provider. And certainly if a woman's lying in a pool of blood hours postpartum, that should trigger the initial response. I think that the drape is specific to the trigger for the bundle so that we can really look at the bundle elements, but that in current practice, these drapes aren't used, and in different areas of the facility where the woman might be postpartum or in recovery, it will be something different in reality, like a pad or a chucks underneath the woman. I hope that answered your question.
Yeah, it does. Yeah, so I think this is I'm not seeing any other questions. So my last question, I would like to know a bit more about the champions that we talk about in one of the solutions around motivation.
Right.
Yeah, so selection criteria and how do you get to what is it that they're expected to do?
Oh, okay. Well, champions sometimes will just rise. There'll be people who are in positions of influence, who are passionate or dedicated about saving mothers' lives from postpartum hemorrhage and see the bundle as something where they can make a difference. The selection criteria will be different in each of the countries and maybe by facility, by the clusters. So I can't tell you, one flat criteria for being the champion. But champions will, again, they're influencers who feel very positively and strongly about this. And they can do peer-to-peer training, they can mentor, they can encourage, they can influence their peers in a variety of ways.
Okay, Thank you very much.
By yourself.
Pardon? Yeah, so thank you very much for again, I see no further questions.
Okay.
I think for me, it's an interesting work. I would really love to see the outcomes of this work, and I hope this is some of the solution, because what we need indeed are simple solutions to resolve this issue. Sometimes when we put very complex solutions, again, we find that it becomes very difficult to implement.
Right. I just want to say one other thing, because it came up in the last conversation. There are many, many interventions and strategies that we use to manage postpartum hemorrhage that are not included in this bundle. We call them best clinical practices, and they are also part of correct and evidence-based postpartum hemorrhage care. So the fact that, for example, emptying the bladder is not part of the primary response bundle does not mean that we're saying you shouldn't do it. And so we have also lists of the best clinical practices that should accompany the implementation of the bundle. So thank you.
Thank you for making that clarification. So I think we'll end here. I guess we all need to get back to the main group.
Right.
Thank you very much for the participants. Thank you for the questions.
Thank you.